And I want to thank everybody for being here today on what is going to be another very informative webinar with Dr. Bonni Goldstein. In case you missed it, Bonni was with us just a few months ago for a webinar, and that is in our client education series at realmofcaring.org. It's also featured on Goldstein Wellness and it's on our YouTube. There's many places you can find it. If you haven't seen it yet, I promise it's worth watching. But today we are here to talk about cannabinoids for the symptoms of autism. So Bonnie is going to take the lead and discuss cannabinoid therapy for autism spectrum disorders, reviewing what the science shows, talk about her own clinical experience, and even address the recent controversies with acetaminophen and autism. Really excited for this conversation. And if we have time, we will do a Q&A at the end. So just use that Q&A box. And if we don't get to it by any means, or by chance, we will still find a way to get you your questions answered, whether that be in a follow-up interview blog or directing you to places on our websites where you can find that information, but we will get it to you. And without further ado, I will pass it over to Dr. Bonni Goldstein to take us through this thoughtful conversation.
Thank you so much, Sasha. Hi to everybody. Good evening. I'm in California where the sun is setting and it was a windy, chilly day, believe it or not. And I know the rest of the country's starting to see fall and winter. So welcome you this evening. We're going to get started. I've got a ton of stuff to go over. And if you're not familiar with me, I've been a licensed physician since 1991 here in California. I trained at Children's Hospital LA, and I worked critical care transport and emergency medicine for many years. And in 2007, 2008, I was asked about cannabis by a friend fighting cancer. I didn't know anything. I educated myself and I became intrigued by the science and by the medicinal potentials of cannabinoids. And so I've been in the field ever since. I have a practice called Canna Centers, and then I've also just recently opened up a platform for education, but also for patients to have connect with educated clinicians and with resources to help find what might work for in the cannabis world for particular conditions. I also have a slew of memberships and advisories, and I'm not going to go through that because I want to get to the material. And then, by the way, this is my book. All right, so let's talk about autism. And the first thing to say is, of course, how do we describe or what is the definition of autism? And this is from TACA, a developmental disability which causes significant social, communication, medical, and behavioral challenges. And of course, I think it's very important to say that autism is a spectrum. There are individuals that need substantial support, and there are other individuals that need no support. My role as a clinician is to help those who need support. And of course, not everybody needs help. But what I want people to realize is that I've been doing this now. I've been treating pediatric patients with autism now going on almost 12 years, 18 years as a cannabis doctor. There's no question in my mind that cannabinoids have significant benefits, especially under medical supervision. There's nothing to fear, very easy to work with. What else can we say about autism? It's diagnosed approximately 4 times more frequently in boys than girls. And again, that comes from multiple places. And of course, there's this understanding that the prevalence is increasing. That could be a whole nother lecture. I'm not going to go into why or how, but we think between people having children later in life, the cesspool of chemicals that we live in, and also just better diagnostic criteria. I also have a lot of patients in my practice that may have a genetic syndrome or some other condition, but they get the diagnosis of autism, which they really don't meet the definition, but they get the diagnosis so that they can get the services. It shouldn't be so hard to get the services that some of my patients need, but I do see that a lot of clinicians will make the diagnosis just to be able to start treatment earlier rather than later. What about diagnostic core symptoms? So the two that you see in the center, so social communication deficits and the restricted interests and repetitive behavior, sometimes called RRBs. These are the two main, what we call core symptoms. But as you can see, there's a whole constellation of co-occurring challenges, things like anxiety, irritability, depression, OCD, sleep disturbance, GI disturbance, underlying genetic conditions that may lead to other challenges, motor problems. And then also at the bottom here, you see different levels of intellectual ability, different levels of language, and different levels of adaptive abilities. And so there's this, again, going to this idea of spectrum, each individual is different. And when we're looking at cannabinoids, it's important to keep in mind it is not one size fits all. CBD is not going to work for everybody. But what we're looking at is how may these cannabinoids fit into this very complex neurobiology, right? Behavior challenges and just overall regulation. I think that's the way to kind of take a look at it from top down. Now, there are two FDA-approved medications in the United States, and they're both to treat irritability of autism, risperidone and aripiprazole. They're both antipsychotics. They have serious long-term side effects. Short-term weight gain, I had a patient who gained an 11-year-old who gained 40 pounds in 3 months. You can have diabetes, metabolic syndrome, drowsiness, tardive dyskinesia, increased prolactin, which is a hormone that can lead to breast growth, and in boys it can happen. It's reported that 40% of patients do not respond to this treatment. I suspect it might be a little higher, might just be that I see a skewed population. Other off-label drugs are also used, SSRIs, antidepressants, stimulants, antihistamines, anxiolytics, antipsychotics. Often the side effects are intolerable and there's low efficacy. And if you delve into the research, there's really not great research supporting the use of these drugs, especially in developing children. And core symptoms are not addressed. That's very important. We're not addressing the issues. And oftentimes I understand why parents seek these out and use them. And I do have patients that combine these drugs with cannabinoids. And for me, when someone is having challenges, a family unit is having challenges, everything should be on the table. But of course, we want to live in the world where we do no harm. And so I do not think that cannabinoids should be last resort. They should be first resort, and under medical supervision, again, tremendous benefits for certain patients. And we have a lot of options under the cannabis umbrella, and we're going to talk about that. All right, I'm going to address acetaminophen. I really don't have time in this talk to focus on the potential causes of autism, but I just want to mention this just because it has been in the news. And what is the worry? Why are we worried about acetaminophen? Well, the way acetaminophen works is because once you ingest it, it converts to a secondary compound. And then it goes on to inhibit one of your inner cannabis compounds called anandamide. Anandamide is an endocannabinoid, inner cannabis compound. And when you inhibit the reuptake of anandamide, you make anandamide hang around longer. So what you're doing is you're interfering with this underlying endocannabinoid system. And the question is that dangerous? Well, it could be because a developing fetus relies on a functioning endocannabinoid system for proper development. So the same way that you might say, a pregnant person should not smoke THC or take a big dose of CBD, although at this point, for me, if again, it's case by case. I usually recommend not using cannabinoids during pregnancy, but there are times where there's a compelling reason to do so. And of course, lowest dose possible for the shortest duration. But it's similar. They interact with the endocannabinoid system. Now, what I want to share with you is this is a paper that just came out this year. It's a review of the 12 highest quality studies. And by the way, this paper was written by researchers and experts from all over the world. So Denmark, Switzerland, Ireland, Germany, USA, Australia, Canada, Israel. And what they found was that some of these studies do suggest a possible link between acetaminophen and a child born who later gets diagnosed with autism, but there were major limitations. For example, who was included in the studies and how well they adjusted also for other factors like genetics, other family background issues, and also health conditions. Now, when they looked at brothers and sisters, where one pregnancy involved acetaminophen and another didn't, the connection between acetaminophen and autism and ADHD actually got much weaker, which tells us that much of what we're seeing could be explained by shared family or environmental factors, not the medication itself. It's also really important to remember, why would you take acetaminophen while you're pregnant? If you're having an infection, fever, pain, virus, or some other uh, something else going on, maybe it's the underlying factor that could be interfering with the baby's developing brain and body. And so sometimes it's from the reason for the medicine, not the medicine itself. We do know the risks of untreated fever are likely greater than an unproven, likely small risk of acetaminophen. That being said, what's the current medical consensus is that it is somewhat inconclusive, but it leans towards low risk. And you'll hear many doctors say, I tell my patients that if they have a fever, they can take one dose and then there's no untoward outcome at the end. It's very hard to study because there's a zillion factors during pregnancy that are just like during the rest of the time. What are you eating? What are you exposed to? What's your genetics? And so on. Right now, of course, same thing for me, what I recommend is lowest dose for the shortest time. And of course, consult your healthcare practitioner. Leucovorin's also been in the news. What is leucovorin? So it's a prescription form of folinic acid or vitamin B9. So folate is the natural form. Folinic acid is the synthetic version that provides the active form for the vitamin. Normally, folate, it's a key nutrient for brain development. We want folate. It gets into the brain through these special receptors, which are called folate receptor. And in some children, they have antibodies to these receptors, which blocks the folate that's in their bloodstream from getting into the brain. So it's not that they don't have enough folate, it's that the mechanism to transport it is not functioning, is being blocked. And so when the antibodies are present, you can sometimes see improvement of symptoms by giving folinic acid supplementation. It's safe, it's well tolerated, it's either prescription or some people often get it from a compounding pharmacy to avoid some of the excipients that are in the bottle, the extra ingredients that they put in. I wanted to show you this graph or this bar chart from a report that came out in 2020. The green bar is no improvement. The blue bar, is improvement. The blue bar is no change, and the red bar is someone who was worse. So it's 44 children in this study who tested positive for the antibodies, and they got leucovorin supplementation, and they just looked at what percentage of patients had improvement. So you can see if you look at green just for improvement, you see receptive language over 50%, expressive language, verbal. And again, these are kids who had the test, okay, who did show antibodies. Also attention. What about no change? So it didn't appear to help with aggression, as you can see. Nonverbal communication helped with some kids, but not others. And then in terms of getting worse, it was really hyperactivity and a few patients here and there in these other categories. So in general, like I said, it's safe and well tolerated. It's certainly something you should talk to your child's doctor about, or just go online and do a little bit more research to see if it's something. You don't have to have the test. I know patients who have just been put on leucovorin prophylactically by their neurologist, and they just kind of reassess to see if it's doing anything for the child. All right, so we're going to move on to the endocannabinoid system. And so this is a system that is excruciatingly important to your well-being. It regulates basically how you handle stress. When stress comes at us, whether it's an infection, some type of traumatic insult, what happens is that we kind of take the hit and then our body goes into survival mode. How am I going to respond to this hit? And the endocannabinoid system is activated. And the idea here is that we release our inner cannabis-like compounds that bind to receptors that then tell the cell, change your message. So the message of overinflammation, dial it down. The message of nausea is an over message, dial it down. The message of pain, anxiety, it's an over message, dial it down. All of those messages are adaptive. And I joke around and say, like, if a bear is chasing you in the woods, yes, you want stress, you want your fight or flight system to work. But when you're just sitting in your house and you have a panic attack, where did that come from? That's your chemistry, and your endocannabinoid system should be kicking in and regulating, keeping your messages between cells balanced. And we call that homeostasis. And when you look at where the endocannabinoid system is located, it's all over. And that is why cannabis as medicine treats so many different conditions. It's because your endocannabinoid system infiltrates every system. In medical school, you learn about the pulmonary system, cardiovascular, hormones, your neurology, but this is the link that ties it all together, right? And so you can see here mood, focus, sleep, learning, pain, immune system, and this is a short list. In the gut, digestion, motility, and control over the microbiome, controlling stress hormones, reproductive balance, and your emotional being. It's excruciatingly important. And this is why we talk about cannabinoids to treat conditions that may have an underlying endocannabinoid system issue. The idea here is that you're augmenting or enhancing or balancing a regulating system that already exists in your brain and in your body. Now, this slide highlights some of the research that suggests that children with autism may have some differences or alterations in their endocannabinoid system. This first one was one of the early ones in 2013, where they drew blood on children with autism, and they drew blood on children without autism, and they found that children with autism had dialed up cannabinoid receptors, type 2 cannabinoid receptors, which are type 2 cannabinoid receptors are involved in immune function and inflammation. Why would those be dialed up? Well, we suspected at the time that maybe these kids had obviously an underlying chronic immune dysfunction. And what's happened when you get upregulation of your receptors, meaning your body puts out more receptors, it's usually because your body is looking for providing a target. Your body's really smart. It wants to be in balance. It's providing a target for those inner cannabis-like compounds. But where are they, right? And it turns out 5 years later, the first report here, this is from Stanford in 2018, that they found that children with autism had lower levels of one of their endocannabinoids called anandamide. And the way to think about anandamide, ananda means bliss in Sanskrit. So when they discovered this compound, they named it the bliss compound because it helps with relaxation, emotional balance, communication between brain cells. It helps control pain. It's such a very important compound. And then the following year in 2019, a group, Dr. Iran's group in Israel, also discovered that children with autism have lower circulating levels of endocannabinoids. So the way to think about it is, like we all know, people have vitamin D deficiency and they supplement with vitamin D. We don't have anandamide to give to you, but guess what? THC mimics anandamide, and CBD can actually sometimes help. CBD actually enhances your anandamide levels by blocking the breakdown of anandamide, but also targets many other receptors that help provide that homeostasis or that balance that I'm talking about. So again, the idea here is the cannabinoids is medicine. We are not band-aiding. We are not making a child, for lack of a better word, stoned and sit on the couch and then, you're not a problem. That is not what we want. What we want to do is to help get everything into balance or as close to, so that a child can function and reach their potential and have a very good quality of life. So it's really about augmenting and balancing an endocannabinoid system that may be altered or dysfunctional. So now we're going to, this is important. We don't know yet whether this underlying imbalance is the cause of autism, it's a consequence of autism, or a parallel feature. And I think that's a very interesting question, and it's something that hopefully we'll figure out in time. But at the same time, we know that children with autism have these irregularities in their endocannabinoid system, and cannabinoids may help balance that. And I've done some research on this. I'm going to share a slide at the end that shows you some of my research where cannabinoids given to children with autism kind of moved these biomarkers that reflect inflammation and aggression from really very high or very low kind of to a very kind of that what we call the physiologic range. Now, autism is not just related to behavior, it also has medical and multi-systemic aspects, as I've mentioned in one of the slides earlier. And what you see here are three biologic systems that are often out of balance in autism. Neuroinflammation. And so, one thing to think about is that your brain has immune cells called microglia. They protect it. If you have a head injury, your body dials up your microglia to clean up, to protect, and to react to that injury. In some people with autism, it appears that the microglia stay overactive. So what they're doing is they're releasing inflammatory chemicals that can interfere how the brain communicates, or brain cells communicate with each other. And we call that neuroinflammation. And it can absolutely cause behaviors, interrupt focus, and cause mood issues. We also know that there's neuroimmune dysfunction in children with autism. So the brain and the immune system are always in constant conversation. And when that communication gets mixed up, when there's too much immune messaging, um, it kind of propagates increasing stress in brain cells. And you just have this imbalance that also contributes to the microglial overactivity. And then also there's we talked about antibodies earlier. You get an autoantibody presence when you have this neuroimmune dysfunction. And then there's GI imbalance, and you get dysbiosis, you get leaky gut, or what we call like broken intestinal permeability, and also immune activation. And so we know that the endocannabinoid system is active in all of these areas to help modulate and, again, balance out. So with plant cannabinoids, these are all proven outcomes when plant cannabinoids are studied: decrease microglial activation and cytokines. It helps regulate T cells and immune signaling, reduces gut inflammation and permeability, and very importantly, restores the neuroimmune gut balance. Now, I'm just going to briefly talk about the cannabis plant. Many of you know this, of over 500 compounds. There's a family of about 160 phytocannabinoids. That number fluctuates depending on what day it is, in terms of what article you're reading. But we have so many different cannabinoids. Of course, THC and CBD are the most well known and well studied, but there's a whole slew of others that we use in clinical practice. We also know that the plant has terpenes, which are essential oils, and also has flavonoids. I'm not going to get a chance to go into much of this today at all, because we're going to focus on the autism research. But this is what the cannabis flower looks like. If you look up close, you see these little antenna-like projections. Those are called trichomes. Those are the factories where your cannabinoids and other compounds are being made. So just be aware that the plant gives us this whole slew of compounds. All right, we're going to move on to research because there's a ton of it to talk about. So this was the first published article looking at cannabis in a child for autism. It's a case report of a 6-year-old boy. They used what's called the ABC scale, or the Aberrant Behavior Checklist, before and after. And this was not natural cannabis. This was dronabinol, which is a synthetic THC. THC is the compound that mimics anandamide the best. And they started with 1 drop, which was 0.62 milligrams. And if you're not familiar with the milligrams for THC, let's say an adult would come to me and say, I'm not sleeping very well. What dose should I start with? On average, around 2.5 milligrams. In a child, I usually start around 0.5 milligrams, or 1, depending on what size they are. So 0.62 is right in the ballpark there. And then they titrate it up. And you can see that over time, he ended up on 2 drops, I think in the morning, 1 drop in the afternoon, 3 drops at night, total daily dose of 3.62 milligrams. This is not a high dose. This is not really, it just depends on the person. And if you're going to ask me, does it impair? When you start low and titrate up, it gives your body a chance to develop a little tolerance. When you develop a little tolerance to THC, you get a wider therapeutic range. You would never start out of the gate, start taking 10 milligrams if you weren't using cannabis or THC before. That would not be a good idea. He had no adverse effects. And just to move quickly here, what you can see is that all of these different symptoms, he rated very high on the ABC checklist. And after 6 months, you can see that all of these numbers on the checklist went down and he had improvement in all these areas. So this is a compelling story of a young man who benefited from very low dose synthetic THC. This is one of the first reports, like a clinical trial of CBD. And I will share with you that most of the research is on CBD, and I'll share those with you. And then we're starting to move into the other cannabinoids to test those. But again, CBD is the most researched and has the most support if you're just looking at the scientific literature. So this was 60 children with severe symptoms. The age range was 5 to 17 or so, 83% males. In the paper, they say 77% were low functioning. And what I understood from one of the researchers that was involved was that these were many kids where the family was kind of at the end of their really at the end of their rope. They were really struggling. They were treated anywhere from 7 to 13 months, and you're going to see this ratio a lot in the research. This is being used a lot in Israel, where they are allowed to study this. So 20 to 1 CBD to THC. They started with 1 milligram per kilo per day, and they titrated up. So then to 2 milligram per kilo per day, then to 3. And what they decided in the beginning was that non-responders, meaning if the child did not get a good result, they were going to add in extra THC. And what that does is that lowers that ratio from 20 to 1, depending on how much THC you add in. And again, you just divide how much CBD, how many milligrams of CBD, divide by how many milligrams of THC, and you get your ratio. They went down to as low as 6 to 1. And basically, they saw that almost a little over half, so 52% responded to 20 to 1, and 29% out of the 60 required added THC. See, and this is why it's not one size fits all. 13 out of the 29 got much better with a little added THC in the mix. And another 7, so basically another 20 kids did better when THC was added in. 6 had no change and 3 were worse. There was a 73% retention rate. This is a pretty high number in a study of people who want to stay on the study medicine. Why did patients drop out or stop using it? Either irritability, they refused the oil because it doesn't taste very good, and then also low efficacy. Parents felt that it wasn't worth it. In terms of adverse effects, so they saw restlessness, irritability, or some appetite loss, which is kind of the opposite of what people expect with cannabis. Higher doses of CBD can suppress appetite, not in everybody, just in some patients. I've had patients who actually have increased appetite, and I have patients that don't appear to have any effect on their appetite. So very individual response when you're talking about appetite. Restlessness, I just want to address that. CBD is stimulating in lower doses or alerting, kind of like caffeine effect. But your reaction to caffeine does not mean how you're going to react to CBD, but it can be stimulating. In fact, they're looking at it for as a treatment for narcolepsy. And higher doses of CBD tend to be more calming and more sedating. So to me, when you see restlessness in lower doses, you would actually go up on the dose to see if you can get a more calming effect. And the same paper I just want to show you, for behavioral outbreak, 61% were either labeled it as much or very much improved. For anxiety, 39% much or very much improved. Same for communication, almost 50%. 1/3 were able to drop lower other medications, and 24, so about 1 in 4 were able to stop other medications. And also only 8% needed to add or increase medication. And what you see over here, sorry if it's kind of small to read, but all patients are listed in the red are in the red bars, and then just boys. So if they remove the girls from the analysis, it seemed that boys did a little bit better than girls in terms of the response to this particular CBD. This is another report out of Israel, 188 patients, and this was in 2019. 82% male, and you can see the mean age there. So it was a big range of about, like 5 up to 20 or so. 7% were under the age of 5, so there is no age limit. I have treated as young as 2 for autism, and I've treated as young as 6 weeks for epilepsy. in this study, 27 of the kids had a dual diagnosis of autism and epilepsy, and then 7 had ADHD. And why were these kids being treated? Well, 90% had restlessness, 80% rage, and almost 80% with agitation. And what did they give them? A 20-to-1 again. At 6 months, 82% were still in treatment. 30% reported significant improvement and 54% reported moderate improvement. You're talking about over 80%. And you can see for slight improvement and no change, just a small percentage of patients. But 25% reported side effects. And again, the most common is restlessness. And again, I always question whether or not that's dose related. And maybe people didn't know to go higher, or that wasn't explained to them. One thing to remember too is that this is all studies are going to look at side effects in the real world. If a family were to one of my patients reaches out and says, my child's bouncing off the walls, we change things right away. We don't make you stay on a certain dose because you're not in a study, and of course we're looking for good results, and we individualize treatment. What about benefits? Less agitation, less rage, better sleep, better focus. And for those kids that had tics or seizures, those decreased. And then this slide just shows you the range of dosing. And this would have been helpful if they had done it in milligram per kilo, because that is really kind of how we dose things, because children are growing. We don't want them to outgrow their dose. But if you look here, on the bottom is the dose of CBD in milligrams. So this represents 3 kids taking 15 milligrams. So you see there are some low dose responders. This is how many kids? Like 7 kids getting 30 milligrams and so on. But you see there's a bunch of kids up here getting 180 milligrams up to 285. And again, this is 2 to 3 times a day. So some of these kids were on pretty high doses, over 600 milligrams. But it kind of clustered around the 45 to 75 if you look at kind of the more common dosing. But here it shows you the average dosing. This is a very wide range of CBD. And the idea, remember, CBD is a very wide range of dosing. I have patients that literally only can tolerate 5 to 10 milligrams, and I have others over 1,000 milligrams a day, and everybody in the middle. It is not one size fits all. For THC, the dosing is much more narrow. You can see a range from 1 to 7 milligrams. Now, in this report, they added in 1/4 of patients that had insomnia, they did add in THC at nighttime. And again, low dose, under 10 milligrams, which is not really, again, dialed or titrated to the child's tolerance, to the child's response. It's very important that it's, again, not one size fits all. This is a study that shows it's the first placebo-controlled double-blind comparison of 2 cannabinoid solutions. They basically took 150 kids, split them into 50 each, 3 groups, gave them 1 arm. So for instance, placebo for 12 weeks. And then after a 4-week washout, they got whole plant extract. And the same thing for the other groups. They did all of these baseline analyses in the beginning, and then all of these analyses as they went on to see how treatment was helping them, but also comparing placebo with a purified CBD, meaning just CBD and THC extracted from the plant, put in a bottle, versus the whole plant, meaning nothing's extracted. It's just how the plant grew in a 20-to-1 ratio. And again, these were patients that mostly had severe symptoms. And the idea here, what they showed here is that what you can see is that this is whole plant extract, is the red bar. And this graph represents the percent of participants with a positive response. So 49% of the kids that had whole plant responded. And remember, it could be from the different groups, depending on which they got. The purified is here in the gray. So 38% had a positive response. But in terms of statistically, this is the placebo, 21%. We look at statistical significance to determine whether or not the outcome is by chance. And when you have a very strong, there's a less than 1% chance that this is due to chance that these patients had this good response. So what that tells you is that this is a true medication effect. So it's a very nice study. They looked at adverse events as well. There was no severe adverse events. That means side effects. The most common side effects, so somnolence, Feeling tired is much more likely if you're taking other medications in combination with high dose CBD. Here again, decreased appetite, tiredness, and then for some patients, anxiety, which is kind of interesting. And maybe they stopped at a certain dose, they were a little ramped up. But again, in clinical practice, we can address that with other cannabinoids or with changing the chemovar. Some other things that they found, very interesting, a decrease in BMI was noted. So participants with a higher body mass index at baseline had a prominent decrease in BMI following treatment, meaning no weight gain. Remember when we talked about the pharmaceuticals that are offered to children with autism, there can be very significant weight gain. Males were more likely to improve on behavior, compliance, and social ability. Younger children were likely to improve on clinician assessment and parental stress. Somnolence was more common if they were on other medications as well, and that was highly statistically significant. The whole plant extract remained significantly associated with improvement on clinician assessment and on social ability after they controlled for some of the side effects and for the other drugs. And here you can see the average treatment. This study puts it in milligram per kilo. So if you have a 20-kilo child, 20 times 5.7, I'm just going to round up. So 20 times 6, 120 milligrams per day, probably divided in a couple doses or 3 times a day. And so you can see, though, that the whole plant and the pure on almost very much the same. Here's another study. The reason I'm showing you this one is because it's a different ratio. Look at that, 75-1. So this was a small study, though, only 18 patients, but they gave these kids a 75-1 ratio oil, and they did monthly evaluations in the clinic over 6 to 9 months. They reported their data a little bit different than some of these other studies. So 60% had a greater than 20% improvement in hyperactivity, motor deficit, sleep, communication, seizures. 80% had a greater than 30% improvement in ADHD, sleep, seizures. 77% remained on treatment. And the 4 that had a negative response were all taking multiple psychotropic medications. In my practice, I do have patients that come in on multiple meds, and I usually will say, let's get started on the cannabis first. And if we see something that's beneficial, then we can start weaning. I don't usually wean ahead of time, but if somebody's on a very complicated medication regimen, sometimes it's helpful to wean a little bit beforehand. I very rarely use this ratio. I don't find it to be all that beneficial. However, there are children in my practice who have sensitivity to THC and they just get kind of glazed over even with a tiny dose. That's their sensitivity, individual to them. And for those patients, I will use these higher ratios because we want to try to avoid that glazed over look. Next study, the reason I chose this one was, this one looked at blood work in these patients. So often people will say, well, is it going to show up in my blood? Is it going to change something? And so this was a study. They had 59 children, at young adults as well, 5 to 25 years. Again, the 20-1 ratio for 6 months. The mean daily dosing slightly higher than what we just looked at, but they assessed a slew of blood work. So complete blood count, which looks like your white blood cells, red blood cells, platelets, and so on. Glucose, kidney function, electrolytes, liver enzymes, bilirubin, lipid profiles, thyroid function, prolactin, and testosterone. And they found no clinically significant differences in the blood work between baseline and 3 months. And I will share with you, I've had patients on these, on CBD and other cannabinoids now since 2013, and we are not seeing any changes in blood work. They did see elevation of one of the liver tests, LDH, and then some of the thyroid, but they were within normal ranges. So they changed or shifted, but they did not go out of range, out of the normal range. In this group, there were 14 children taking other medications, and they did not see any differences in their lab tests as well. This is just a review that came out in 2021. They looked at 13 studies, 8 were finished and 5 were ongoing. And I just think this is nice to share with people. All studies reported substantial behavior and symptom improvement. 61 to 93% of the participants in the study showed benefit. And remember, I said early on with the antipsychotics, 40% don't respond. That means like 60% get some response. in the cannabinoid studies, what we're seeing is much higher, 61 to 93% showing benefits. Of those where they measured whether or not patients could reduce medications, 80% of those participants were able to reduce medications. And they did see mild adverse side effects in 27%. Again, that's 1 in 4 about. And what I would say to that is that's fine. I see it all the time, but we change in the real world. We change what you're taking, or change dosing, change product, change cannabinoid, change timing. There's lots of things we can do to avoid side effects. Now, this one I wanted to show you because of the ratio. Again, this one looked at children with autism between the ages of 5 and 11 for 12 weeks. And it was a very low ratio compared to that 75 to 1. It's about half of the 21 at a 9 to 1. And they just did drops. I'm not a big fan of using drops because, you know, if somebody moves your arm, you've got a child that's wiggling, it's hard to get drops in the mouth. But that's what they did. And what they saw were all of these statistically significant benefits. So if the p value, it just stands for like what the chance of having this be that it's actually due to the intervention, due to the medicine. If it's less than 0.05, that means less than 5%, it's likely that it is due to the intervention. So social interaction, highly statistically significant. Improvements in anxiety, agitation, interesting number of meals a day. So maybe less picky about food. Also, maybe because it's a lower ratio, triggering some appetite because the THC has a little more activity. And concentration improved, but only in those children who were rated with mild, and only 3 children had mild adverse effects. So you can see there's this wide range of dosing, and people say, well, where to begin? I usually start, if you ask my opinion, I usually start at around a 25 to 1 ratio because that's something that's easy to find and seems to do the trick for the fair number of patients. Now, this is interesting. So this is, it's really hard to find any research on adults with autism. And so I pulled this one out. This comes from the UK Medical Cannabis Registry. They approved the use of medical cannabis in the UK a number of years ago. It's a complete disaster for pediatric patients because no neurologists want to get on board with it. But for adults, they have access. There were 74 adults. The mean age was almost 33. 81% were either current or already using cannabis. So what does that tell you, right? They were already finding it helpful. 69% reported anxiety and depression in addition to their autism diagnosis. They were able to use dried flower. That means that they're using cannabis material to smoke or vape. 22% were using oral or sublingual preparations like tinctures, and 30% were combining or using both. And this is the dosing. Now look at CBD is only 10 milligrams a day, but look at the THC. That's a pretty high dose. But again, what I tell everybody is we don't judge the dose if that's what that person needs. If they are highly anandamide deficient, if they don't absorb very well, if they have very extreme aggression or really difficult behaviors, sometimes high dose THC is needed. And so I don't ever judge. In fact, I have a patient right now who's a young, well, now he's in his early 20s. He takes somewhere between 200 and 300 milligrams of THC 3 times a day in addition to his CBD. And that's what keeps him able to function. He's able to leave the house. He's able to go out to dinner. He's able to participate in his life. So we should not judge the numbers when we're talking about medical use. As long as somebody is doing well and they're not having side effects and they're not losing the medicinal benefits due to tolerance, I don't ever judge the number. Now, how did they look at these patients? Here's all the scales. So basically this top one looks at all kinds of stuff, mobility, self-care, activities, but it's a quality of life measurement. They looked at a sleep scale and they also looked at an anxiety scale. And what they saw in this group of adults was significant improvements in general health-related quality of life and sleep at 1 and 3 months, and also sustained changes in quality of life and sleep at 6 months. And again, side effects were mild to moderate, and nothing here unexpected or potentially dangerous. Now, this is interesting, and this is one of the studies. This is from 2022. It was an open label trial. It's 110 patients. It's, again, 20 to 1 ratio. But this was really the first report that documented that CBD addressed core symptoms. And so they found overall significant improvements in social communication abilities and restricted repetitive behaviors. Interestingly, and I kind of mentioned in a previous study, larger improvements in those who had more severe initial symptoms. Interesting too, findings were not associated with age or dose. It doesn't mean if you didn't start when you're 5 that you shouldn't use cannabis when you're 20. There was no association at all with age, but they did not find any significant changes in cognitive scores. And the final dose, they stayed at under 10 milligram per kilo per day, or a total of 400 milligram per day, which is interesting because, as I've mentioned, I have patients on much higher than that. And also for THC, they really stayed very low, no more than 20 milligrams per day. And they still got very good benefits. And so I think this is a very nice report to show that CBD addresses core symptoms. That is why I think that cannabinoids and CBD, when I say CBD, I mean CBD dominant, full spectrum, high CBD, a little bit of THC in there. This is why I think should be first resort. And those other drugs that have such difficult side effects and also just address only supposedly irritability should not be first resort. I just want to show you this. This is a small study, 24 males. They rated moderate to severe, and they were also on at least one other medication using a 33-to-1. So we didn't see that ratio before, but that's what this group chose to treat their patients with. And again, they started with 1 milligram per kilo per day and titrated up. And I'm just going to show you this chart. And I do recommend take a look at this because it's an interesting paper. And again, it's a small study, but I just like the way that they visually showed their results. So dark green is great improvement. Light green is some improvement. White bar here, as you could see here, is no change. And then anything worse is highlighted in that kind of light pink. But what you can see, great improvement and some improvement for, and this first one here is communicative intent, is this the majority of patients, right? The majority participating. If you look at LE, learning, the next one is attention to others. So all of these wonderful improvements that you see. And what I like here too, this very last one, expressive language. I mean, very nice results, okay? And then this one, I kind of highlighted some things there, but I'm going to go a little faster for time. Here's a second bar graph that they show, and this is their clinical assessment of changes in repetitive, restrictive, and dysfunctional behavior. So look at aggression, very nice results. Look at irritability here, and then if you look down here, this is self-aggression. So you see, and very little risk, right? And so, and again, in the real world, if you end up in this little category here where you're much worse, you change it. There's no reason to stay on something that's making you worse. Okay, what about additional cannabinoids? So I have started using CBDV. This is cannabidivarin. It looks just like CBD, except there's a little tail on the structure. I'm sorry I didn't include it. But instead of 5 carbons, it has 3 carbons. That's what makes what we call the varins. Those are just another group of cannabinoids that are in the plant. And in rats, they found that CBDV really reduced autism-like behaviors and restored the endocannabinoid system and the glia. Remember the microglia I talked about? It restored those glial alterations in the rats, and they use this prenatal valproic acid is just a mouse model of rat model of autism. They also found here that a single dose of CBDV in adults with and without autism, when they compared an MRI, they found that CBD restored this atypical signaling in the brain to a neurotypical range. This is just put this article up if you want to take a look. It just is a nice review of CBDV for both epilepsy and autism. And then I just share with you, this is the one human clinical trial of CBDV that's published, although there's some research that some pharmaceutical companies did, but that's not, I'm not going to bring that up. But that was in adults with epilepsy. But this is in 5 little girls with Rett syndrome, is a neurodevelopmental genetic syndrome that falls under the category of autism. They did a phase 1 clinical trial and these patients had was very well tolerated. So the idea here with this study was, safety and efficacy. Yes, it was very safe, and yes, it was very effective in this group, 79% reduction of seizures. But I've started using CBDV in my patients, and this is what I've seen. And this is some unpublished clinical reports. I'm gathering data, hopefully, to publish, but improved speech and comprehension, better sleep, less impulsivity, better social interaction, better eye contact, improved behaviors at school, less aggression, happier mood. These are all parents from parent emails. What I do want to share is that most of these patients are combining CBDV on top of an already existing cannabinoid regimen. So they may have been on CBD and THC and maybe CBG, or whatever it is for that particular child. So this is not by itself. Can you use it by itself? Sure, you certainly could, and see how it works. Side effects in clinical practice, I've not seen any. In epilepsy. It either works or doesn't work. But in autism, I have had a few kids that have been agitated, similar to the handful of kids in my practice that don't tolerate CBD. And why, you might say, why? These compounds are very what we call promiscuous, non-selective. They hit multiple targets. Most pharmaceutical drugs are designed to hit one target. These compounds are they hit multi targets. And for some patients, I believe that one of the reasons that it may not work out well for certain patients is because we're hitting targets that we don't want to hit. And that's where that promiscuity or non-selective property of these cannabinoids may not be beneficial. Could also be that something in the full spectrum. So sometimes I very rarely use isolates, but sometimes I'll use it in a child who's struggling with unwanted side effects. Now, what about THC? So I've said it twice already. THC mimics anandamide. And Dr. Iran, in that one study I showed you, 1/3 of participants with autism did better with the addition of THC to their CBD regimen. And clinically, I find it helpful for aggression, self-injury, and insomnia. As I mentioned, some kids tolerate very high doses without any evidence of impairment or intoxication. I often usually include it in a regimen that includes CBD, which helps mitigate tolerance. There's something I call the ceiling dose. Every person is different. What's the ceiling dose? That's the dose at which you become impaired. You want to stay under that, but then you could build tolerance a little as if you're on it for a longer time, which then means that ceiling moves up. And of course, the chemovar matters. What kind of THC are you using? And I usually encourage people to use calming terpenes. CBG has not been studied in autism, but it is anti-inflammatory and anxiolytic. There are reports of benefits, improved speech, mood, focus, more socialization, less hyper, less anxiety. Maybe alerting for some people. So I usually recommend when you're trialing CBG, just take it in the morning only, see how you or your child does. And also the chemovar matters. Remember, if I grew cannabis in my backyard and you grew cannabis in your backyard, even if we start with the same seeds, they don't turn out the same because all of the environmental factors when you're growing cannabis. So we call that the chemovar or chemical variety. So again, by definition, different brands usually have different chemovars. And you may need to try CBG from 2 or 3 different companies to see which one suits better. THCA is raw THC. It's anti-inflammatory, non-impairing. It's not been studied in autism, but I have used it. And there are reports of better speech, calm behavior, less hyper, less aggression, less anxiety. It also can help with seizures. I like a ratio of about 20-1, almost impossible to find these days because just our dispensaries here in California are really targeted more towards recreational use than medical. You do want to keep it refrigerated because it can convert to THC if left out and heated up. CBD is the raw form of CBD, meaning you have the flower. Remember that flower I showed you, and you make a product out of it without heating it up. So it's a potent anti-inflammatory. It's anti-anxiety. It's non-impairing. And again, there's one study I'm going to show you next, reports of less aggression, better focus, less symptoms of pain, happier mood, less anxiety. And again, I usually tell people to keep it refrigerated. One of the main uses in my adult patients is for inflammation and pain, and it can be quite effective. This is a study that came out of Australia, and just a disclosure, I do after they published this, they invited me to be an advisor for their company, and they are looking to get this product into the United States. It's 62% CBDA, 14% CBD, and then some minor cannabinoids, very low THC. It's only 14 patients, but they all had moderate to severe symptoms, and they titrated up over 4 weeks, starting at 5 milligram per kilo per day and going up in the same increment. Looking at safety and efficacy, 14 of the 18 completed. There were 18 initially, so 14 completed 4 weeks. 64% tolerated the max dose at 20 milligrams, and again, this is safety as well. 36% tolerated between 6 and 19. So again, that wide range. CBDA kind of mimics CBD that way. There's a wide range of dosing. 36% did report stomach upset, which then resolved. It was like, was it a bellyache from the CBDA or not? No, there was no intervention, and it went away, and they stayed on treatment. No serious side effects, and this is a very nice number. 93% showed improvement. And when you look at the improvement, what they saw was statistically significant improvements in clinical severity, anxiety, agitation, behaviors, attentiveness, and more than half of the caregivers and participants reported decreased anxiety. So even the caregivers have less anxiety, right? So, and this just kind of breaks it down for you. And again, in the interest of time, I just have a few more slides that I want to show you before we run out of time here. This is my biomarker research. So what we did, what you're looking at here is just 3 of our 15 children that participated. We collected saliva in the morning before they took their medical cannabis, and then we collected saliva a couple hours later after they took their medical cannabis, and we measured all of these different metabolites or biomarkers, basically chemicals that we make in our bodies, in these children. And what you can see is this blue zone. So here are all the different biomarkers. Each line represents a biomarker. This line straight down was the average for neurotypical children. And the range, this is -2 to +2 standard deviations away from the mean. So our physiologic range is within the blue. And you can see that this young man, all of his biomarkers, many of them are falling outside of that range. Same for our little patient here, and same here. And after they took their medical cannabis, we collected those biomarkers again. And by the way, we did behavior assessments in the morning and behavior assessments in the afternoon, or with their after a couple hours of their medical cannabis. Parents tell me all the time my child's doing better. In the medical world, nobody believes you. That's anecdotal. Drives me crazy. If a parent tells me their child's worse, I believe them. Why shouldn't I believe them if they tell me their child's better? Well, one of the reasons we did this research was to prove that it's not just in the parent's head. Look at that. All of those biomarkers shifted into the physiologic range after they used their medical cannabis. Almost all of them. And so that correlation of my child is better because he's less anxious, there's better focus, he's not as aggressive, he's learning better, the schools were telling me he's doing well. Well, look at this. It correlates to an underlying physiologic response. And so we're hoping to get this test to be able to test children before they start medical cannabis, so we have targets, and then we can understand which cannabinoid to use to address which biomarker, which chemical pathway. So we're still working on that, plugging away. All right, some clinical pearls. CBD dominant products, to me, that means the ratio is over 10 to 1. As I mentioned, most studies are 20 to 1. I like 25 to 1 personally. CBD, THC balanced products, I call them balanced when they're almost the same. So under 10 to 1, but remember, the THC plays a more prominent role. So probably that wide range of dosing is going to be a little bit more narrow, because the THC, as you go up, it comes along for the ride. It's going to start causing some impairment. Most use 1 to 1, but some customize. You can have separate bottles, CBD and THC, and just add in the THC little by little, which changes that ratio little by little. So you can trial and see what might work best. Watch for that ceiling dose. I talked about that impairment. So red eyes, sedation, munchies, silliness. You can trial other cannabinoids, as we've talked about. Most patients take 1 to 3 doses per day, again, individual, customized for the child. I usually recommend starting with a morning dose and adjust the timing based on the response. Do not make a change in your child's medicine and send them off to school because it takes 2 hours to kick in. You want to observe on the weekends or observe after school, unless your child's homeschooled or is at home. You really do not want to send your child out the door on a new dose of anything until you see under your supervision. I had a very awful case of a child being reported to Child Protective Services. It's rare, but it happened. And so it's left a bad taste in my mouth. So I just tell people, change your medicine when you are watching your child or someone you trust is watching your child. We've talked about the biphasic effects of CBD may also exist for CBDV. Always shake the bottle before you drop the dose if you're using tincture, and also use a 1 ml syringe for accuracy. And then, Sasha, do I have time for 2 reports, or do you want to stop and take questions?
Let's do two reports because you're answering some of the questions as you're going, and
Okay,
and I will send you the ones that weren't answered, and we'll send a follow-up email this week to everybody so that way they can
oh,
get
great.
the answers. Yeah.
Great. Okay, thanks. Okay, so let me just share 2 reports. This is a 5-year-old that came to me nonverbal, occasional aggression, mostly directed at mother who had black and blue marks on her arms, rare self-injurious behavior, sensory seeking, picky eater, poor focus at school, very hyper and anxious, very rigid, but was sleeping. And the mom reported he seems unhappy and anxious. He doesn't like leaving the home. He did not like going to school. They tried guanfacine, which is a medicine for behavior. And they were also offered risperidone, but the parents read about the side effects and were reluctant to use it. Week 1, I started him on CBD THC. Now, by the way, this particular mother had already purchased a bottle of a 20-to-1 and brought it to the appointment and said, I don't know what to do with this. And I said, that's fine, we can use it. So we started at 1 milligram per kilo and just titrated up over a couple of weeks. So some people, this is what I'm going to tell you. There's 3 responses when you start treatment. A good response, if you see that, watch for a while, see over time. Everybody's allowed to have a good day or a bad day. You cannot tell by one day. You need at least 4 to 7 days. But if you get 7 days of a good result, you can hang out there for a couple weeks and see, and then try to go up again. If you don't see any result, you're not getting it into the system. You got to dial it up. If you see a bad result, now it depends on what it is. So if your child is acting out and it's high CBD, that could be to the biphasic. Don't wait. You might want to try one more day because, again, anybody can have a bad day. But if it appears to be making your child worse, you want to dial up. Less aggression. This child, less aggression, seemed happier. He was a CBD responder right away. We kept continuing to go up. We're looking for the best dose, what gives us the best result. Now, sometimes you have to pass up the best result. Oh, now he's sleeping all day long. Nope, that's not good. And we back up. It's important to take notes so you remember which dosing helped your child the most. Again, less hyperactivity, smiling more, better compliance, and he was trying new foods. I remember they told me he tried pizza. They were so excited. By month 4, they were very excited. So far, he was doing very well. We added CBG. I believe he kind of hung out at the 7 milligram per kilo for a few weeks, maybe up until month 4. And then we added CBG. He said his first words, he said mom, and he said TV, which he called his iPad the TV. He had better eye contact and better mood. And he's been basically staying at this, and great reports from school. And the parents are very happy. He's sleeping at night. We talked about adding in other cannabinoids. Fortunately, the family is stretched thin financially, and they said for right now they're going to sit on this. But we did discuss trialing CBDV next. But they've been very happy. And again, he's been adding words. Speech therapist even said he was doing well. And so that's just a kind of a very simple report of a good responder. This is a 16-year-old nonverbal, severe aggression, no self-injurious, but was aggressive towards other, very sensory seeking, hyper anxious, did not sleep at night, had some sexual aggression, was not in school due to behavior, had gotten thrown out of 2 schools. And his mother, frankly, was a bit afraid of him because she had been hurt. They trialed 3 different antipsychotics. He had been on an SSRI. He tried Adderall, which is for ADHD. And he was currently, when he came to see me, on risperidone and lamotrigine, which is a Lamictal, if you're familiar. It's used both for mood stabilization, but also as a seizure medication. Not great results. Now, the parents gave him a 10 milligram gummy right out of the gate, which is what I told you not to do, but they did it. And they reported to me he had a great day, but he seemed a little stoned. So they were basically saying, look, we want to explore this. We saw our child have a good day, and we want help. We want to find a cannabis regimen. So we started this child. I started him on a 1-to-1 ratio. And again, severe aggression in a big kid, not sleeping at night. The sexual aggression is a little concerning, unable to be in school. So THC, remember, we are treating that underlying endocannabinoid deficiency. And the studies show that some of the kids who have worse results do better with some THC in there. So he started at 5 milligrams of each 3 times a day, and we started titrating up in 2.5 milligram increments. Less aggression, calmer mood, improved sleep, but still waking at night, but less than he was before. We kept going up, and he was at 7.5 milligrams of each CBD and THC, continued to have gains, better compliance, less anxiety, less aggression. Week 5, we went up to 10, and the mom said he seemed tired and was very silly. So I think it was a little impaired. So we reduced to 7.5, back to the dose where he wasn't impaired. And we added in CBG in the morning and titrated up little by little. And he had improved alertness and balance. I'm not sure why I wrote balance. I'm sorry about that. I'm not sure why I wrote the word balance. But month 3, we decided to trial CBDA. The parents were motivated to kind of try whatever I had recommended next. So we titrated up to 25 milligrams in the morning, and he had significant improvement, further reduction of anxiety and aggression. He was sleeping better. He was less hyper. He began communicating with his AAC device. He started homeschooling. And so this was his current regimen the last time I checked in with them. So look at that. He's got basically 4 cannabinoids in his regimen. And what I'll share with you is that there's no question in my mind that combining cannabinoids can be very helpful. They overlap, but they also enhance each other's effects. So you can sometimes get away with lower doses. And then just in summary, so research supports the use of cannabinoids for challenges associated with ASD. I'm going to tell you that some of the studies I quoted today, the final thing says, we do not recommend using cannabinoids until there's more research. For me, what I've seen in my practice, plus the research, I believe it supports the use, especially when you compare to other options, which are very limited. It is safe and well tolerated. Cannabinoid treatment is safe and well tolerated, but it has to be customized. It is labor intensive. So very rarely do we hear about, oh, I gave my child the first dose and everything was hunky dory after that. It can happen, but that's uncommon. Research supports CBD dominant around a 20-to-1, but again, there's a little leeway, but some may need some of these other cannabinoids. The benefits I think we've talked about, and start low and go slow. And what I write about this in my book, Rule It In or Rule It Out. You start something, you titrate up, you try to dial in. You either rule it in that it works, meaning you found a dose that's helpful, or you've ruled it out. Get rid of it and try something else. Combination cannabinoids provide enhanced benefits. About 75% of patients respond overall. And THC is very safe under medical supervision, although there can be a ceiling dose. And everybody asks me about development. You need to have a functioning endocannabinoid system to develop if you have an endocannabinoid deficiency. We are using cannabis medically. We are not using it it's not the same as a 15-year-old smoking behind the high school. Okay. It's a completely different world. Okay. And then I just want to say thank you to everybody. This is the website Goldstein Wellness. And if you are someone looking for help, you can get started. And we do not charge patients to connect them. We can connect you with Realm of Caring, who you already know, but we have other lots of clinicians and practitioners on our website who I've educated and mentored, who now can help patients use cannabis safely under medical supervision to find great results. All right, so I'll stop the share and happy to answer questions. I do have about 15 minutes. If you want to take the time, Sasha, or if you want to hop off.
Excellent. We did have some people start to say goodbye because they asked their question and
Yep,
the left, knowing that I'm going to send them out. So I think what makes sense because we have a lot of great questions. One came in from Australia, another from Peru, a lot of good questions about terpenes and things that you didn't get to cover. And I think if we do a comprehensive follow-up where I send you the questions and we can send it out to the audience in our newsletter, I think that would be probably the best option.
perfect. Yep,
Okay, great. So
great.
I will send them out and then we'll get it out to everybody here. Thank you for the thoughtful questions. I jotted every single one down. And if you didn't get a chance to write it in the Q&A box, you can always send it to info@realmofcaring.org and we will get that question answered as well. But thank you so much, Bonnie. This is great. And also one person said that you just answered their question. So thank you because you started to answer it.
Happy to do so. Yep.
Yes. Thank you so much,
It's
Dr. Bonnie.
we could do hours on this. I
Yeah, I
mean,
know.
right?
I know. That's the
I
next
didn't
one.
even get to talk about beta caryophyllene or some of the other things
Yes,
that we
and
can
that was
do.
one of the
Yep.
questions. It's on
Oh, well,
BCG.
let's do a talk on beta caryophyllene because that's a very helpful compound. And so, 1 hour is not enough time.
You're
And
right.
that just goes to show that when people say there's not enough research, yes, there is. There's a plenty of research and at least to show that it's safe and well tolerated.
Yes, and I can't end on a better note than that. So thank you so much, and we'll follow up with everybody here. Thank you for joining us today.
Bye bye, everyone. Thank you.